Charlie. My computer is.
All right, Charlie, whenever you say go, we're good? Okay. So, ladies and gentlemen, welcome to the January 23rd REMAC meeting. Okay, we're going to start with a roll call attendance, and then we will get going.
When I call your name, please say present. Robert Winchell. Joseph Schenker.
Here.
Michael Batch. Robert Ackerman. Laura Ivacoli. Stuart Kessler. Matthew Fink. Wallace Carter. Eric Cohen. Kevin Munjal. Cindy Basilios. Here. Grace Cacciola. Dario Gonzalez. Glenda Sada.
Here.
Bradley Kaufman.
Here.
Nathan Reisman.
Here.
Pamela Lai.
Here.
Sophia Borgens.
Here.
Nicholas Alexander.
Here.
Doug Isaacs.
Here.
William Hausner.
Here.
Kevin Ward. Anne Marie Genti. Andrew Dahl or Allison Burke. Jeffrey Raybridge.
Here.
Lauren Costurco. Reed Caldwell. Jonathan Berkowitz.
Here.
Lewis Marshall. Michael Redlunner.
Here.
Dominic Battinelli. Efren Rendon. Peter Wire. Or Eric Whittinger. Paul Barber.
Present.
David Benelli.
Here.
Mary Foote. David J. Miller. Mark Cantor.
Here.
Ed Jarvis. Nicholas Ficcari. Joseph Bove. Sean Graves. Jessica Van Voorhees. Benjamin Zabar.
Here.
Matthew Harris.
Here.
Robert Groupie.
Here. Michelle, just Petrel is here. She's on Zoom. She's on mute, so she may have responded, but perhaps wasn't.
Doesn't count if you're not
Doesn't
physically
count
here.
towards the quorum.
Oh, okay, just
Participate in the
that's
meeting.
fine.
Right.
No problem.
Arthur Cooper. You did your Langsam. Anthony Shalish.
We're just gonna check for a quorum.
Richard hasn't been here in a long time either. Yeah, it's true. Dario. That's his alternate. Yeah.
For the record, Sophia Georgians will act as the alternate for Dario Gonzalez.
Excellent. So we do have a quorum, so let's get started. So we're going to go a little bit out of order because we do have a presentation from the QA committee, but I just want to first approve the minutes from the November 21st meeting. If anybody has any questions or comments about the minutes, please let me know.
Motion to approve.
Second. Excellent. So all in favor, just raise your hands. Great. Anybody opposed? No? Good. Okay, so the minutes are approved, and we're going to move on, like I said, out of order. We'll start with a presentation from First Watch from the QA committee. Dr. Redlener.
Good evening, everyone. It's nice to be here. And today we have Sylvia Verdugo from First Watch, who's been our point of contact for our First Watch project, which, as everybody knows, is a dashboard for regional use around the mission lifeline measures, both STEMI and stroke. It's been a project that's been extended by a pandemic, but we have been working over the last 6 to 8 months really to engage all of the agencies that are part of the First Watch project, bring them on board, make sure they have access to the dashboard. And we wanted to bring Sylvia and her team here today to talk a little bit about and show and demonstrate a bit about the dashboard, answer any questions, make sure people, there's clarity around what this is and how it can help us. And so I will turn it over to her. Thanks so much for being here.
Thank you. And then if you would just give me access or privileges to share screen, I can get started.
You all set?
Let's try again. Yep, I got it. Thank you. As you guys were doing roll call, kept on smiling. I was like, oh, I know that name. I know that name. I've seen that person before. So it's really nice, not to be there physically, right? But at least, you know, see the names in action now. Okay, so I know we have a little bit of time, so let me go through this. So like Dr. Rogner said, we have been going on for this project for a little while, the New York City and AHA regional dashboard for a while. So I will go through some very basic information here that I have written in a couple of slides, and then I will move on to the live dashboard so you're able to see it. So but just wanted to provide you a little bit of background information to see how this came about, what the data is coming from, what we're measuring, and so on. So this project, we have the participation of different agencies, different hospital and EMS services from the New York City. So the slide that you're seeing right now is a list item of all the people that have agreed to participate. We have from these agencies, First Watch was able to get a data connection. By the way, people that haven't heard, First Watch is a software company. We're based in California. We handle all kinds of data regarding EMS and safety. And we do data analytics and with that information. So what we did is after that grant was funded, we started talking with the different agencies again that you see on screen. We started getting data connection to the electronic patient care records, as well as the online medical control data through the telemetry system. So all of these systems we see, the majority of them shared their EPCR data that was based on Health EMS Ansio Striker. We did have one agency, Senior Care, that has Health EMS Ansio Striker and also Creative EMS for their non-emergency or 911 calls. And then we had Citywide, which we had EMS charts initially. I think Citywide dropped that year, I think one, because they changed data sources. They changed their electronic patient care record. And decided not to continue to participate after that. So for Citywide, we have a limited database, I think, of about 1 year. Everybody else, we have starting with, I think, at least 2 years of data worth. So once we had data connection and data started flowing for all of these different agencies from their different EPCRs or from telemetry, what we did is that we passed that data or that information over to one of our modules in First Watch, which is called First Pass. So First Pass is our clinical quality improvement tool. And then again, this image is just meant to describe what the system or the tool does. So again, after we have a data connection to the electronic patient care record, our kind of the very first thing that we do is try to identify the groups of types or categories of calls that we are interested in looking at. So in this case, the two types of calls that we were trying to look at are the AHA STEMI and AHA stroke. So we went through the process of defining, okay, what is the definition for these calls, right? So what is the case, the criteria, or the sort of the denominator for what constitutes a STEMI call and what constitutes a stroke call. So once we had those definitions in place and we had them all, put into neat little packages of different categories, we call those protocols just on the First Pass world. We then took these calls and passed them over onto our software, the module for First Pass. And the intent of the First Pass system is for us to be able to code or build logic that is continually screening every single EPCR record, again, that meets the criteria for the protocol, again, STEMI and stroke in this case. And so we predefined that logic or test metrics or questions that we're asking of those types of calls. And then the system at the end will do, again, what machines do best, which is, order, scan, and give us sort of first review saying, this particular record met all of the criteria or the logic that we had built in it. And this call gets a pass, right? So appropriate patient care was built according to the rules that we have built in the system. Or there is at least one metric, one test, one question that we have coded into the system that was not met, right? And this can be for multiple different reasons. So essentially it's calling an additional reviewer or a human person to go in there and take a look at these calls that were flagged. So again, this is overall the intent of First Pass system. And again, like I mentioned, all of their participating for agencies were built into this first pass module. We give access to each of, our main point of context or clinical point of context from each of the agencies. So they had the ability to go into the system review calls and then, provide outcomes from it. So in regards to what metrics, again, metrics, test questions that we build under the first pass system. In the screen, you have two columns where we have the AHA, STEMI, and AHA stroke defined metrics that we decided to build, right? And these metrics, right now, when I look at them, they look pretty straightforward, but it really took us a long time to be able to define what it is that we wanted to measure. And then also make sure that the logic behind the scenes accounted for all of the little nuances that we have from the different agencies. If you remember, the majority of our participating agencies were based on the same EPCR platform, so Sansio Stryker, but even though it's the same EPCR, crews document differently, right? So the different agencies have different rules set for their crews in terms of documentation. So we not only needed to make sure that we came up with the appropriate definitions of what constitutes a STEMI and what constitutes a stroke call, but also from each one of these tests, from each one of these metrics, that we are appropriately accounting for every single way or every particular way that each of the participating agencies could document things a little bit differently. So if I just quick little example. So again, this is a screenshot of the sort of behind the scenes logic for one of the metrics that we have over here. So this is, again, it's just 3 lines. It's much, much longer, but I just wanted to show you. It's just 3 lines of code behind the test if chest pain contact to 12 lead less than 10 minutes, right? So pretty straightforward metric or test when you think about it. But again, you have to take into account, not just are we measuring things the same way, right? But are we taking into account, like I said, the nuances in documentation for each one? So highlighted in yellow, you would have the different ways that our participating agencies could measure EKG 12 lead. Like I said, very easy procedure and straightforward, but each one of them can have one slight difference that we need to account to. So you're seeing the first line is overall how the majority of the participating agencies would document it. So that's a description, EKG with a K and then a -12 lead. But second line, we have how Mount Sinai has a description, right? So, and then sorry, the third line, how senior care, right? All 3 of them are measuring EKG 12 lead. But again, it's those little nuances from within each agency that you need to multiply by 10, 11, 12, depending on, again, all the agencies that were participating on these metrics, right? So again, though that was a big lift for all of us to be able to make sure that we were measuring appropriate metrics and then also making sure that they were billed appropriate for each of the agencies. So again, that's talking about the data. Obviously, once we had, case definitions defined, and then the logic behind all of the metrics had been vetted, not just about what we're measuring, but also, if we're measuring appropriately in terms of the logic for each agency, then we took that data from first pass and started actually building, a dashboard. So when the grant was funded, this image over here that you have that's the original dashboard mockup, right? So that was the idea behind it when we were proposing to say, yeah, we can help with this project, right? So this was the original mockup, and then it started evolving from there. So the very first versions were still in a sort of not old, but yeah, I'm going to call it old, legacy system that we're basing report writing based on SSRS, so SQL Reporting Service Studio. So this was the very first version, and from here we started modifying, right? So if you see, also the metrics are different, right? So as we were evolving the visuals of the dashboard, we were working on also redefining what metrics we were building in here. So that's the first version, and then from there, second version will incorporate a little bit more information from scene time, which was something that, again, we added in there too. And then after that, we said, okay, maybe this visual from this sort of static view from the SQL Reporting Studio is not the best. So we transferred all of the data and all of the work that we have done from that sort of legacy system onto something that's more versatile, which was Power BI. So this is a dashboard that was built on a different platform. As you see, again, the dashboard is evolving, right? The metrics are there, but then the visuals are a little bit different. And then this is the very last version, I think, that we did. This is version number 3 before we jumped. So again, visuals are a little bit different. We're incorporating different information here and there. But again, what I'm trying to show you is how this project has been very iterative, right? So my concern initially with the project is making sure that I was providing the appropriate information in terms of what I'm measuring, right? Because it's very hard for somebody to tell you this is your percentage of compliance on your stroke and STEMI calls. If that happened to me for, if it were my agency, I was like, okay, show me, right? So it was our job to really show what the case definition was for each of these calls, and then also the logic behind the scenes, and really be transparent into what it is that we were measuring, how. And then obviously, you guys know your agencies better than anybody, right? So it's learning from each one of your agencies about what works, what doesn't work in terms of documentation. And then at the same time, right, looking at the clinical side of the house about what metrics are we measuring, right? What's important to keep track, what will make a difference.
Sylvia,
So
can
go,
I
please.
interrupt for 1 minute? Yeah, just,
Sure.
I think what this has enabled is all of our data from across the agencies that are participating to come to one place, alongside a kind of comparison of all of our agencies side by side. And it allows for us to kind of really talk about data in a very serious way about what we're accomplishing, and if there are specific ways in which we can improve. And so again, this tool is very powerful, and it's something that we can continue to use and as we go forward, both on an agency level and on a regional level.
Thank you. Okay, so I have moved from my sort of slides of the history of the dashboard onto the sort of live dashboard, right? So this is what we have in present, rolling and available for all of our participating agencies. Again, happy to provide any additional access to anybody. And then we have been working really closely with Joseph with that. At the top, I'm going to start at the top, right? So this dashboard has the ability to move data and be a little bit interactive, right? So we have different agencies, right? So these are all of our participating agencies that we have masked their name, right? So we have put a code behind it. And then obviously we can, depending on access level, happy to share, level of access for agency codes for different, people or different access, right? Again, coordinating with Joseph about who has access to what. So again, this dashboard gives you, like Dr. Rudlander was saying, information on these particular metrics, but also the agency has the ability to compare them side by side without having the ability kind of to poke fingers and to say, no, I'm doing better than you, I'm doing worse, right? Just very transparent in the information. So again, we have the ability to filter this by the agency. We have the ability to filter this by any date range that you would like. And then, left section over here at the top, we have the different metrics. The dashboard moves depending on what I am selecting, right? So the dashboard is predefined to select AHA stroke metrics, but I can easily move over here into STEMI. When I do that, all of my graphs, everything that I see turn, right, they change. And I can choose to say, okay, I want to select all of the metrics, or I just want to select one at a time. Right? So I can see only blood glucose. And again, once I do this selection, everything changes. Bottom over here section has, again, the information for percentage of compliance for each of the big protocols or big types of calls, but then over here, the percentage. And then we have some boxes over here for tests, right? So test pass means, the amount of or the percentage of calls that were gotten that little green flag, right? That little, all good, everything was checked. And then we also have numbers over here. We see data over here over time about those past calls. Again, and we're grabbing data from 21, 22, 23, and then obviously working on 24. So this is page number 1, right, of the dashboard. I'm looking over here at the bottom. And then on tab number 2, we have, again, information regarding still stroke and STEMI, still with the ability to filter by the type of call. still with the ability to filter by agency and by date range. But here the dashboard is displaying information regarding times, right? So left side is talking about the median scene time. Again, I'm looking right now at the stroke. And then on the right, we're looking at median times for 911 to destination, again, on stroke here, right? So again, we have the data over time over here, and then the graph on the bottom, it's giving you the minutes, right? By the individual agency. Like I said, I can move from stroke to STEMI, and then the data adjusts. Okay, ooh, I kept on time. Okay, so that's, I kept to my little time frame. Happy, this is what I have to show you. You guys, I had a little bit of time, so I wanted to make sure that I kept to that. I'm happy to answer any questions that you would have for me. Happy to provide a longer time period of an overview if you would like. So I'm gonna stop sharing. And then any question that I can help you with.
I would just say that some of the I mean, some of you have probably gotten access to the data for your agency and for the region, and so I definitely look at it, explore it. I think it's a great way to drive your own decisions about what you're working on, and again, it enables us to move the region forward together. And looking at this data is pretty, without being over revelationary. If that's a word, you can kind of look at what's going on in the region. So
You can move to make it a word.
But you could be revolutionary.
revelatory. Thanks.
There you go.
I got an expert advice here.
Excellent. So thank you, Dr. Redlener. Anybody have any questions for Sylvia? Any comments? Okay, so Sylvia, thank you very much.
Thank you.
While we're here, I think we'll finish the QA/QI report, Joe, if that's okay, and then we'll move on.
I will leave you then.
You can.
Okay, thank you, everybody. Bye.
Joe, you have anything else, or Mike? The QA report. I'll let
Sorry,
you
yeah,
finish that and then we'll move forward.
Sure. In addition to our discussion about our update related to the first watch and what Sylvia presented today, we talked also about the CARES program and the advances that we're making related to that. Mount Sinai Health System, both the EMS and the hospital side, have started their participation in CARES and have started entering data. It's the first set of data into the CARES database for New York City. And I know that the team is progressing to engage all of the health systems, the larger health systems, as well as all of the EMS services. The report from the field is that it just takes seconds to minutes to enter a report once it gets into the data set. So there's lots of good things that could come of this, and it'll enable us to talk about cardiac arrest. We discussed that. They're going to come present a short presentation next month to update us about what the progress has been. In addition, we approved the Staten Island EMT course sponsor upgrade application to go to REMSCO. Our job was to make sure that they met all of the criteria as elucidated by the state, and we felt that they did. So that will go to REMSCO for final approval. We interviewed a paramedic on a case restriction that will go forward to a CIC for remediation. That was essentially the meeting report from quality. Thanks.
Great. Any questions for Dr. Redlener? Okay, thank you. So now I'll go back to the agenda. We'll get back to the order here. I'm gonna go back to the correspondence report, and then we'll get into subcommittees and so on. The correspondence report from the fire department. The fire department search and rescue field medicine symposium will be held on May 2nd to 5th. Is that correct, Dr. Isaacs?
Where did Dr.
He
Isaacs go?
stepped out.
Yes, the
But
dates are
he
correct.
asked specifically that we bring it up again, so I just wanted to make sure he was aware that we are mentioning the FDNY Search and Rescue Field Medicine Symposium
You probably have some
on
posters
May
you can give out
2nd
after the meeting.
to 5th, 2024.
Yes. I'm sure Doug has extra posters he could give out.
And it's on the webpage.
Yes.
Okay, from the New York State Department of Health, your BMS, a letter from Alda Sniga, MD of Medical Director, informing REMAC that New York City Health and Hospitals is a primary stroke center. That was approved on January 17th. Drew Chesney informed the council that New York State DOH will be moving forward the sunset of the EMT critical care curriculum. So thanks to them for following us. Christopher Langevin from New Milford, Connecticut, EMT certificate number 153229 is suspended for 1 year effective November 8th for violations of 10 NYC RR Part 800.3 and a whole lot of others. The suspension is stayed pending no further violations for a period of 3 years, and he was assessed a civil penalty of $1,000. A save the date for the next RTAC meeting was sent out. That will be held on February 5th. A letter was sent out to Dr. Prezant to basically allow what is now called the Treat in Place, formerly the ET3 agencies, to use the current protocols that were approved and that do not need to go up to CMAC and SEMSCO for approval. And that is all the correspondence that has a time-sensitive nature that I will read in. We also received actually one more thing. We received a resume for a nurse to fill the community EMS or the community RN position. Nurse, her name is Kelly Gorman. She has experience as both a flight nurse for Northwell and NYP stroke unit nurse. She was a paramedic, an EMT, and we do have a vacant seat. So unless there is somebody specifically that has a concern or complaint, or if there's any other interest in a seat, this will go to REMSCO for a vote next week to join this committee. Any questions, comments, concerns? Okay. All right, moving forward. Executive committee report. There was no executive committee meeting since the last REMAC meeting. However, we will be reviewing the attendance. First, I want to thank everybody who's here right now for being here so that we have a quorum and that we can hold business. But we will be reviewing the minutes for following our bylaws so that anybody who hasn't been attending meetings will be removed, and that alternates can move into primary positions for people who are here, who come regularly, so that we can continue to serve the medics, the EMTs, and the city of New York. So
Yes,
you
but
have to speak
it's not
into the
allowed.
microphone.
We have to follow the law.
Unfortunately, we have to follow public meeting rules, so we cannot have virtual meetings. It would be nice if that changed. Maybe it will, but as of right now, we have to meet in person. Okay. Any questions about anything we've discussed? Yes, Art.
I do think that emergency providers fulfill a special role in society, and taking them away from their places of work and places of business, I think, is something that, is probably, counterproductive certainly in the long run. Perhaps, we should begin a process of advocacy to work with our representatives in the Senate and Assembly, to get some legislation passed that might exempt EMS organizations such as ours from the public meetings law. Obviously follow all the other requirements, has to be posted online, et cetera, et cetera. The public needs to be informed. They need an opportunity to speak at such a meeting if they wish to do so. But I do think it's worth pursuing. Amy Paulin is Assembly Health Chair. Gustavo Rivera is Senate Health Chair. I think that would be, and I personally would believe it would be favorably seen by the governor's office. Not sure, of course, but I've had no conversations with anybody about this. But I do think it would be an important step for all of us, and I would encourage us to take the lead in this. I would make a motion to that effect. Thank you, David.
So any discussion on this motion? Ben, sorry. You speaking.
I know it's a little bit of a pain, which I appreciate. I do think we have moved a lot of our work virtually, like protocol committee is virtual and medical standards. The ones that don't correlate with REMAC are also virtual. It's a pain, but I think there is a benefit to, being in person, sort of the medical leadership of EMS in New York City is only sort of together 4 or 5, 6 times a year. And, I think it'd be nice to have the flexibility, but I think we may not want to jump fully virtual, even if we do get that flexibility.
That's a good point, and it makes Ben shake.
Yeah, exactly. I think that after going through a 3-year pandemic, there's no discussion or argument whether virtual meetings work or not. Right? I mean, there's no discussion of whether these meetings can be held in a productive and courteous and respectful way. And I think that dragging everyone over here in rush hour all the way to the upper west side of New York is a challenge for everyone. And I am certain that having virtual meetings will encourage attendance.
Anyone else? Okay.
The motion by
So
Cooper,
the motion by Dr. Cooper is that we begin a process to petition our state and local representatives to push the public hearing, public meeting law towards virtual, at least as an exemption for emergency
Yeah.
providers.
I would think that could even be in the form of a letter to those chairs that you mentioned and suggesting that, yeah.
we are in communication with both, maybe Poland's or
Yep.
stuff. We are in communication with, Assemblywoman Paulin and Gustav Rivera from the Senate, so we'll be able to.
It's certainly worth asking and,
And
it-
we've also brought this up at REMSCO
Yeah.
to the states.
well, they have the same issue. They don't get a quorum either as a result.
But they're too busy trying
Yeah.
not to let us credential
Well,
anybody
that's-
to.
All right, we'll get to that when we get to that. Just give us a few minutes. Paul, did you want to add something? Okay. All right, so hearing no more
Having
discussion.
difficulty after talking to the microphone.
I'm talking to the microphone. It's-
Nothing
point
to
is
add.
with me. So hearing no more discussion, and because this is not a protocol vote, we're just gonna take a hands-only vote. All in favor of preparing a letter to these public officials to try to change and support a change in the public meeting law, please raise your hand. Anyone opposed? 1, 2,
Two.
2 opposition. Any abstentions?
We'll go out for drinks instead. Tom.
We can do Zoom from a bar.
Yeah, exactly.
I'm just saying. We gotta get you out of the house. Is that what you said? By the way, I mentioned the field medicine conference, Doug, just so
Yeah.
you were out of the room.
If you have extra posters, we can distribute them.
Okay, thank you for that, Dr. Cooper. All right, let's begin with subcommittee reports. I'll start with certification and credentialing, Dr. Barbara. And we have a bunch.
Speak into the microphone,
So
please.
please speak into the microphone.
Credentialing committee met on January 5th virtually. All were without any issues. It was a revelatory meeting for the record. We would like to bring a forwarded motion from the credentialing committee that went through medical standards at this time. That would be the lead of our report. And that's the modifications to physician credentialing for online medical control and potentially other methods of physician credentialing to come more in line with the existing paramedic credentialing process. Joe Ranieri is here.
He was. He stepped down. Oh, he's
No, he's behind the pillar.
What are you doing hiding, Joe? No, so Joe, can we put these slides up or at least the website up? Charlie, can we put collaboration up? So in short, the move is to organize the existing didactic and processing and payment of physician credentialing for online medical control, New York City REMAC, to the online learning management system known as Collaboration. This would replace the existing process, which is mostly pen and paper, and would bring us into a realm of electronic competency that this region deserves.
So while they're preparing to put this online, basically what we're going to see is the online process so that there's an understanding. But the basic idea here is to take the process of online medical control physician credentialing and put it online like the paramedics and have to do as well. Any discussion on that concept while we're waiting for this to get set up?
Is this only for recertification or what would the initial certification be?
Great question, Ben. This would be a wholesale change to both the initial certification and the ongoing credentialing of all physicians in the region. As there are physicians in flux or people that are out there right now that are yet to be credentialed, this would replace the entire process with a understanding of a sunsetting and extensions as needed to make sure that business operations remain as usual.
I mean, I think what the bottom line is that the process will be the same. So if you're doing a class to credential providers, you'd still do the initial class the similar way, but the paperwork process, which is very arduous, would all be incorporated into the LMS, which makes it a lot simpler to get everything to Dina to review, and so on.
Much more.
Also, the didactic information remains unchanged.
Right. The renewal process is something that I think everybody here has had a big issue with. Nobody has sat through a second online medical control physician course. It's always been about updates to the protocols, updates to the process, updates to operational guidelines, which I think will be all online, similar to what the paramedics do now.
Yes.
So it'll be a much more streamlined process. You're right in that there are people right now who are in flux. They're either expiring, have expired. The process is not up, it's not online yet. So I think we do have to address people who are expired or expiring and maybe have some kind of timeline by which we grant them an extension until this is up and running and we're ready to go, and then allow them a window to re-credential through the LMS.
Also, a benefit of the physicians being on the learning management system would be that the protocol updates and other annual trainings that are provided to the paramedics and EMTs would also be provided to paramedics, creating an additional bridge between physician and field provider.
They'll be provided to the physician.
It'll be provided to the physician with the expectation that the updates that go to the region go to the physicians in the region, credentialed by the region. Now, Joe has the website up. We're not going to go through the whole thing here, but Joe's been working on this for about 4 months. I have to be honest. Like this ask started in the beginning of the summer, and Joe's been doing the be honest. So with the purpose of the website here, we're not going to go through it now, but basically every physician in the region that's credentialed in medical control will be expected to log into Collaboration and create a profile. Benefits of that is expirations would be, kind of automated. I think physicians don't always know they're expired or they're expiring. You'll also be able to, at the end of the learning path, pay directly, which creates a lot of logistical issues for the REMSCO staff as well as hospital staff. So streamlining the process that exists from pen and paper to the LMS has significant benefits. Of the learning path will be addressed with the regional OMC faculty in a small group meeting after this meeting is passed. And we'll have Joe go through everything for the instructors that are providing medical control instruction in the area. Does anyone have questions or want to ask anything with the website being up?
Well, would there be an opportunity to put this out to at least a select group in like a beta version to get some feedback on?
So the idea is there's a couple of people who need to recert and we asked them to hold until this meeting.
Okay.
With the idea that those will be our beta testers with a lot of understanding that first, this might require revisions. But since we have a tight group of faculty that have been the original education providers, I'm confident that the transition points are worth the benefit of any risk of.
Yeah, no, I
Beta
thought it'd be
issues.
great to be able to get some feedback from some users and see.
We're going to follow the initial credentialing very closely to see what needs to be tweaked. But having Mr. Ward and Mr. Lax and Joe, who launched this exact process a year ago for paramedics, I'm confident that the issues they ran into on the paramedics are now an understanding at the physicians. And also our scale of physicians is much smaller than the launch for the paramedics. Regarding medical control faculty, if you're an existing medical control faculty, we'll meet you in a small group later. Moving forward, we're gonna have an expectation of involvement. If you want to continue being a medical control instructor, that may or may not require direct instruction. It may require training, quality, feedback to medical control providers. There's not going to be enough classes to teach for everyone, but if there's training materials that can be generated by people who do a lot of medical control fire department, that would be great to have help to understand the greater training of everyone in the region. We could utilize our partners who do a lot of medical control fire department to help us train the future of physicians.
Any questions? I think that one of the things we'll have to address is the component of telemetry observation will have to be made into some virtual component, whether it is simulated scenarios that have questions afterwards, or something along those lines that can be put on the LMS. And that will be for the regional faculty to kind of work on, so that we do have a component of telemetry observation without any burden for any one facility, because it would be it wouldn't be fair to ask any one facility to be, to carry the burden and be required to have all these observers. But I'm sure there's a way to do it virtually with simulation, and a question answer, something along those lines.
During the pandemic, we had issues getting people to the fire department due to, unnecessary observers situations. I would think of that fire department observation almost as testing out on T skills, or CPR skills. It says you knew it then. It has no movement forward for your competency. And we should be endeavoring each medical control to have their own measures of quality, as opposed to competence at the time they pass them and they're done. So usage of quality devices, like there's an issue with this protocol because we handle 500 calls a year on this specific issue. That kind of information being shared throughout the region is probably more important than 8 hours in telemetry 3 years. So that's kind of where we want to move forward, that quality process and ongoing awareness by all the providers in the region, similar to what our paramedics and EMTs are expected to do.
So this comes forward as a seconded motion, approved to make this change to the LMS. The two things that are in question is the date of implementation. And then I do think that we should, from that date of implementation, probably have a 6-month window whereby people who are expiring or going to expire would have a window to get up to speed on the LMS for their recertification. So I think that that's a fair time frame for those who are expiring or have expired. So basically, we would grant a extension for 6 months from the date of implementation to all REMAC cards that are expiring. And if you expire after that time, then your card will expire on the date that it does. Any questions? And do we want to pick an implementation date? Dr. Benelli.
So the system's set up for both around. So it has the ability, right now I have the learning path for something that would be a new online medical control position. So essentially they follow 4 steps on the path. Most of it just has to do with uploading documents and taking the Thank you, Charlie. We're breaking our own rules. You? All right. So it's essentially, it's a four-step process, mostly uploading documents, and then there's the exam has now been pushed onto the elements. Right, so really the only component that will be necessary from the faculty member will be to report that they taught the course. And we're gonna,
And to give the course, obviously.
yeah, to report that course was given, so that this way we have an attendance list of the physicians that actually completed the training. And one of the things that we'll be doing when we meet with the regional faculty is making the decision on how we want to report that. We have a lot of flexibility in how that can be done. That really will not affect the front end of the process for the all MC candidates. They will know the difference. It'll be really up to the faculty and how you want to make that reporting. And we also have it set up for the renewing physicians to, once you complete the original, you get your credential. The LMS actually gives you on your dashboard a countdown of when you're due to expire, and it automatically assigns you to the path to renew.
Significant issue right now, when you look at the list of expired medical control providers, there's names that may not even know they're expired.
So, Dr. Benelli, to answer the question, the initial course would be the same as it is today. This would just handle the paperwork. The recertification would happen all online, and that's the part that we have to fine tune.
Yes.
Yeah.
It is ready.
And I have people that are waiting to certify that I'd like to run through the process as soon as possible.
Nick,
That was my question, when can we expect that we can actually do it now, because we do have members that are.
correct.
If it passes today, Nick asked a good question.
If it passes today,
We'll choose a date.
we'll choose a date, but, we have to still talk amongst the faculty members, but onboard people in great detail than Joe
Showing these three screens here.
So
Hopes would be that you meet me, you, and the other faculty members to discuss exactly what's happening. And then we can go live. So for week 6 week timeframe would probably be optimal.
Let's say arbitrarily, we
was gonna say
decide
March 1.
today to
Yeah.
choose March 1st as the start date. Okay, let's arbitrarily choose that date.
Mhm.
6 months from then,
September
which
first.
would be September 1st, would be the date that anybody who has expired or is expiring between then and September 1st get their paperwork up to speed. So if you expired already, you would get automatically, your date of expiration would go
September
to
1st.
September 1st of 2024. So somebody who expires today, somebody who expired a month ago, because we haven't had a process to renew people, would automatically move to September 1st of 2024.
So we're saying that there's a grandfathering from now until that time, everybody stays online.
They get, their card gets extended.
Okay,
until- yeah.
right.
and in the wake of no extensions for positions during all the pandemic, as Dr. Zabar pointed out in the last medical standards meeting, this is a good compromise.
Does that seem reasonable to everybody?
March 1st sounds like a good date.
So it's only expired a year ago.
Correct.
There's no expired.
If they expired a year ago, because we haven't really had a renewal process. The renewal process hasn't been, I mean, some people have done it one way, some people have done it another way. You have to send in your paperwork. It would automatically, everybody's expiration date would move to September 1st of 2024.
So. But I think what you're getting is like, how far are we gonna go back?
How
with
far
that?
back?
Like,
That's a good
should we
question.
say like, if you were January 1 of 23 or later, do you get the extension? And we'll go back a year,
I think.
but not
I think-
10 years.
I think that's reasonable.
I think-
1 year is fair.
Yeah.
Because we have most of our protocol updates happen this
Right.
last year.
We maintain a list of physicians with expiration dates. If you're on that list, you should be good. If you're not on that list, you're not part of the process.
Right, but people who have expired on that list, what is the furthest back
Yeah.
that they go?
Right, do you go back
Stand by.
years?
I know Paul has the answer, that's what we'll ask him and we'll get the real answer. But while he's looking at that, does March 1st with a sunset of September 1st sound reasonable for everybody? To put on
So
this.
expiration date, the longest expiration date is 2/1/23 that we maintain.
So I would say anybody, so you, basically, if you are in 2023.
If you're on this list,
automatically Move,
yeah,
your expiration date would extend until September 1st of 2024. So
So people are not on that
Yeah, come on. In the mic, please.
People are no longer on that list if they expired before 2023. They were taken off the list.
So sounds like we have a good plan.
Does that sound reasonable? Okay,
100%.
so I think we're gonna do a roll call vote for this on the motion from CNC to go into effect.
March 1, 2024.
It's a little warm.
Your expiration date, I have the list right here.
Well, the truth is, if you vote, your expiration date immediately moves.
Yeah, it
March
would benefit you to
2024
vote
to
if you're
September
expiring in the near
2024.
future.
This will be the easiest protocol I've ever passed in
done.
history.
I'm recusing myself from just. So the motion is from CNC is to switch the online physician credentialing to the LMS with a start date of March 1st and a sunset date of September 1st, 2024. And anyone who's expired,
Yeah, they're two separate.
it's one. It's
Right.
the second in motion.
But you're not sunsetting this. You're extending their,
Correct, extending.
right.
That's a better way to put it.
extending their expiration date till September 1st.
Correct.
2020.
Okay, any questions? Is that clear? All right, so let's go whenever someone's ready to start.
Vote in favor, oppose, or abstain. Glennis Theta. Bradley Kaufman.
In favor.
Dario. In favor.
Wow.
Wow, Dario, you're so, yeah.
I'm Dario voted for anything
Exactly.
for me.
It's the mustache, it's the mustache.
Nathan Reisman.
In favor.
In favor. That was, yeah, four. Am I pronouncing that correct? Nick Alexander.
Yes.
Doug Isaac.
In favor.
Jeffrey Raybert.
In favor.
Reed Caldwell.
In favor.
Michael Redland. They're gonna get used to this. Passed over, Dr. Shrinker.
That's what we need.
Okay.
Arthur Cooper.
In favor. Oh, look, he's the microphone. That was
Oh,
very
well
proud.
done, Art.
Good job,
Well done.
Art.
Ed Jarvis. Mark Cantor. Robert Krupe.
Can't
You
vote.
can't vote.
Okay, can't vote. David Miller. Stuart Kessler. Wallace Carter.
Here.
Matthew Fink.
Not here.
Either, right? Cindy Basilios. Matthew Harris. Benjamin Zabar.
In favor.
Paul Barbara.
In favor.
David Benelli. Eric Lutinger. So it's unanimous and carried.
Excellent, thank you.
That concludes the
thank-
CNC report.
Thank you to
Good
the
work,
work.
good work.
Paul and
Nah,
CNC
Joe.
on everything you guys have done. Okay, Dr. Benelli, medical standards, please.
Talking to the microphone,
Please
please.
move the microphone to you.
Yeah.
Yeah, right.
So medical standards met on September 9th. On January 9th, virtually. And there are no items that are brought for discussion over here. We devoted some time to discuss again what the CNC presented here. There will be further, protocol committee has a couple of items that are being reviewed and discussed. Will probably be brought to the next meeting. Next medical standards meeting will be meeting virtually on February 6th at
Thank
3 p.m. And Michelle will send out links and everything. Thank you.
Oh, I'm sorry. So just one thing that I might be a good time for us to discuss
yeah.
is when would be an appropriate implementation date for the protocol changes that have been approved thus far.
Good point. So we've approved protocol changes that do not need to go to CMAC. And CMAC did not meet in December. The next meeting is
February 6th,
February 6th, which we hope our protocols will go to and be approved.
6 and 7.
The question that we have is, what is an appropriate time frame for, assuming that there's an approval, what would be an appropriate time frame for training, education, and to go live with the new protocols? I know that Morty is not here tonight, but he did say that the training can be completed by mid-April. So it can be ready for a, I guess, June, like beginning before the summer implementation.
Do you want that
If
or
that's what
July
we want.
1?
So let's discuss that. Let's make the assumption that things will go as planned in February. What do people think in terms of an implementation date?
I mean, do we do July 1 to give you the time to do it or? I'd say June, but that might be too, I don't know if that's too tight.
Well, in terms of, I guess, training cycles, I mean, for the fire department, does July 1st work? Is that the end of a training cycle for you guys, or it's in the middle? It doesn't matter. So there'll have to be a component of the LMS that's mandatory, even if it's an attestation.
That you did the, yeah.
That you reviewed the protocols. You still have to do the protocol update on the LMS. So that attestation will have to be done. We haven't really talked if there's an in-person class, how can a instructor do part of that for you? But the goal is for everybody to do their protocol updates through the LMS.
Yeah, if there's no in person, I think it's a lot easier.
No training
But
cycle.
there's also going to be a BOT update. but
Does July 1 work for you guys
July
or?
1st sounds good.
All right, so I mean, if everybody's in favor, we can make a motion to make our implementation date July 1st. It wouldn't have to be a roll call vote. It could just be by hands. And if everybody's in agreement, we can do that. Art?
Maybe I've been way out of touch, but I had thought that, our start date for implementation of protocol changes was always January 1st.
So it was for a long time, but because of the cycle of CMAC, meaning a change that we made in February would then have to wait a year, which doesn't seem practical.
That was always the problem with
Right.
having a once a year
we're
thing.
trying to make it we're trying to tighten that window a little bit and make it.
So this would be twice a year going forward, or are we just moving it to
Well, I
a
think
different start
CMAC's
date?
plan was once a year to have everything approved by January with like a July implementation for the statewide stuff. So
Okay,
I think we're mirroring that, but
We're
got
trying
it.
to mirror
Okay,
that.
so we're trying to mirror that. Okay. But I have to say, it never made any sense to me that if there's a pressing reason,
Right.
to
Right.
change a protocol, that we have to wait almost a year, whatever the start date
Well,
is.
for a pressing region, I mean, there's
You
always
do
an
emergency.
emergency change that can happen, but if we're trying to educate and operate as a single entity, as a single set of rules, annually is a little bit simpler, especially now that they have the LMS, it has to be updated and cleaned up. Dr. Benelli.
I think that the implementation date would have been much sooner had CMAC.
in
had a
December,
forum,
yeah.
Correct.
In December. And this is unfortunately how the things cascade, and that's why we're doing this. I mean, we all have to desire to do this.
If they met virtually, maybe they would add a quorum.
That's a good point.
That is a good.
I
point.
think that.
Ben,
So just to be clear, I mean, I'd be fine shifting it, but I think we should just be clear what we're the idea going forward, because, for Pam and everyone, if this goes live July 1st, are we expecting the following year's protocol to also be July 1st for now? Are we gonna, which I like having that predictability, because otherwise we're gonna be scurrying around trying to basically say, well, we have to get all these protocols ready by September. If it's good, the next set is gonna be January 2025.
David.
I think that we all aspire to having this in the beginning of each year and not in the middle of the year. But we do need the flexibility in order to accommodate for unexpected things like CMAC not meeting, not having a quorum. But ideally, we could start working now towards the protocol changes of next year. I don't see any reason why not to do that.
Okay, so
And then have an implementation date towards the beginning of next year or a month or two after the beginning of next year.
so tentatively, we'll have the 2024 protocols come out. Will be in effect July 1st, 2024, and 2025. We're working towards January 2025.
I think that's
Yeah, I
fine.
mean, the challenge is that the REMAC and CMAC both meet on an academic calendar.
And they have to
So
align.
we only start in September. To get things done for January is always challenging. But I don't have any problem. I mean, again, if there's something pressing, we can always move the timetable forward if it's something that really needs to be done. There's also again, you have to think about it from the paramedics perspective, protocol updates and having to go through the LMS every 6 months is a little bit more than that's demanding. So maybe annual for something that's not an emergent change, maybe annually does make sense. And then July being our rollout time because of when CMAC meets. I mean, we were always trying to be a little bit in front of them so that we could have that fight with them when we needed to. But the reality is we're working on their calendar because they have to approve some of the things.
Yeah, I mean, I think ideally, right, if the December CMAC meeting happens, that's where we get whatever we needed approved, and then that would give us the latitude to do what earlier in the year. But if that meeting doesn't happen, then we get pushed back.
Yeah, I'm fine either way, but I just think we should decide sooner rather than later if our goal is July 2025 or January 2025.
David.
Just to add on to what Jeff said, most of the protocols did not need to go, most of the protocol changes for this year did not need to go up to CMAC for approval. There are only 3 or 4 protocols that needed CMAC approval and would have been approved in December. So this is really not such a big ask to try to keep the schedule as it is.
I agree. Listen, I think from a practical perspective of updating the LMS, of medics having to update, I think annually makes the most sense unless there's an emergency where we say there's something that critically needs to be changed, in which case it goes out with an advisory and an LMS, a separate timetable. But I think that it's reasonable to have that year, that we would like the year to start earlier. So if it had been December, we probably could have gotten these out in March as opposed to July. I think that's kind of what I'm thinking. Yeah, Paul.
So from a credentialing standpoint, the sunsetting of the cycle of the exam was contingent on some sort of annual update, annual training. So even if we don't have a bulk of protocol updates, it really is inherent to have something going out to the crews to keep thoughts active, whether that comes from the quality committee on, opportunities for improvement in the field or protocol updates from that committee. But the training department really should have some sort of fodder for an annual update that the credentialing committee can kind of depend on, because that was one of the contingencies of sunsetting the test that everybody wanted to do. So we really should have something, whether it's good material or recycled material or ongoing material, but an annual process for awareness is really an annual mandatory training for anybody who's, in healthcare. You get your annual mandatory training every year. Same idea.
I agree.
You want to implement the protocols for July 1st.
Right.
When do the training materials need to be ready?
So Morty has already said that he could have the training materials ready March, April. So there'll be plenty of time to be ready to go.
Okay, thank you.
Well, that's a big, and it's gotta be at least 3 months. It should be like March, April. It can't be the end of April.
Right, it's gotta be by April
No,
1, so you have 3
let's say
months.
by April, like the beginning of April, he can have it ready. That was the message that he sent out.
Yeah, but at least 3 months.
Yeah.
Part of the training material could have been worked on.
He started, yes,
Right,
that's
because
training and
there are
education
things
has
that did
begun.
not require-
Yeah.
Right, and
Yeah.
training and education has begun. They've even begun working on the training material for the stuff that's going to CMAC with the assumption that it's gonna get
Right.
passed.
Just needs to.
as things.
Yeah.
Sounds like you won't need long to get it going once everything's
Talking
approved.
to the mics.
There's
Everybody.
issues with stroke protocol applications. There's other things that.
Okay, so I think what we can say right now is we will do the 2024 implementation on July 1st. And then going forward, I don't know if you want to talk about going forward annually, other than emergency protocol changes, or if we just want to say we'll implement on July 1st for 2024 and address the next year after that. I'm okay either way. What do you think? Anybody? Bueller. What is people's opinion? Do we want to just address this year, or do we want to address, say, that July 1st going forward will be our implementation date? I think, I'm asking everybody in the room.
I say we address this year now and let's see how things play out for the
Good.
year and then.
I would agree with
Yeah.
Excellent. So, Marie, we're talking about implementing the 2024 protocols on July 1st. Okay. All in favor of implementing the 2024 protocols on July 1st pending approval at the state, please raise your hand.
11, 12, 13, 14, 15, 16, 17, 18, 19. Okay.
Anybody opposed? Any abstentions? Okay, thank you. David, anything else? Okay. So training and education, like I said, Morty is not here. He said that the training can be completed by April, and he will report at the next meeting. Interfacility transport, Dr. Berkowitz.
You just turned it off.
There you go.
There you
Now
go.
you're good.
There you go.
Thank you, Nathan.
So we finished the document. So the next meeting, I believe, is early next month. Michelle, you'll get me straight. First Thursday of the month, 2 o'clock, or something of the sort. So we're gonna review the document, and then I'd love if we get a few people to review it additionally. It's about 8 to 10 pages. So if there's a few folks who are interested to review it, let me know or let Michelle know. And I'd like to have a review phase, and then we can bring it up to Med Standards to review as well.
Excellent. Any questions for Dr. Berkowitz? All right. RTAC, like I said, is meeting February 5th. So anybody who can attend or does attend, please attend. All right, Regional Council update, Marie.
Hello. This is the REMSCO report to REMAC. The Regional Emergency Medical Services Council of New York City met on November 28th, 2023. The following motions were approved. The Regional Council approved the expansion of the Bedford-Stuyvesant Volunteer Ambulance Service to a new territory in New York City. The confines of the NYPD precincts 73, 75, and 77 in Kings County, and community boards 5, 8, and 16. We did receive the new certificate from the State Department of Health, and everything is approved and done. We have complete applications for CFR, EMT, and paramedic course renewals that were approved from FDNY, NYPD, ESU, Modern Health Resources, Garrettson Beach Fire Department, B&H, Emergency Medical Services, Emergency Care Programs, Montefiore, NYU, Emergency Aid Training, Queensborough Community College, and Center for Allied Health and RTI training. We have about 34 training centers in New York City that are all pretty busy. Scott Chang at that meeting gave the emergency preparedness update, and the dreaded FEMA COVID-related funds are still in review. Well, actually, he's finished the review now. He's in the final phases of getting reimbursements for the volunteers that were in operation during COVID. He's done a lot of work. It's been 2 years worth of work. And we have agencies that are very happily receiving a lot of money from FEMA. Also, we have intranasal Narcan for any agencies that want it for free, except fire departments. Sorry, they won't let us give it to you for free. because you should have your own channels to get it for free. If you don't, let me know. I don't know what we can do to help, but we have it free for everybody else. Okay. Program agency update. At that point in November, we had submitted our first quarter program agency and regional council vouchers. We've already been paid for those. We, in addition, now submitted our second quarter vouchers and we're waiting to be paid. CMAC, SEMSCO subcommittees are meeting virtually and non-CMAC and SEMSCO members can join. I've said that before. If you want to participate virtually at all these subcommittees, please contact me if you can't get on Boardable, which is the platform that the state uses. They talk about legislation, they talk about protocols, even this rural EMS discussion. It doesn't matter if it's done on the rural platform. Anything that is done in legislation can eventually affect us, so we should have some participation in the discussion. If you can't do it, ask other staff members just to sit in and see what's going on. You'd be surprised. Okay. From the ambulance committee, our security sticker tag, we're working on new decals for ambulances to be used for identification. And we're still working with the vendor. I requested a new quote, never received it. So I'll be going after them again. And of course, we have the congestion pricing problem, which, it's really affecting our EMS providers who don't make enough money to begin with. And now they have to pay to get into lower Manhattan. It's crazy. And it's funny, if you've been in the bus or a train and it says, they have a picture of an ambulance that says congestion pricing makes it better for emergency vehicles, except that they don't have any emergency personnel who can come into Manhattan because they can't afford it. But we are trying to get that point across, and I know fire is also. Mordecai Lax was not in attendance to provide the report about the learning management system. Well, he is working, and Megan Williams from BMCC is doing a great job. She's a new regional faculty, and she's working in collaboration with the Department of Health to really, elevate the use of our regional faculty in New York City and through the state. Okay. I'm not going to do QA/QI updates because we already did that. Okay, and I, as usual, reported on SEMSCO, CMAC, regional credentialing of paramedics, and never-ending story on that. And we have Dr. Isaacs is on that committee. Dr. Barbara, I don't know how he got hooked into being the chair of that committee, but we are working on that. And in addition to this report, for those of you that don't know, the governor's budget just came out. And they have a big section on EMS changes. I haven't done my review yet. I know that the SEMSCO does have subcommittees that made some changes that were reviewed and looked at and were, approved by the members of SEMSCO as being reasonable changes. They should be in there. What I'm going to be looking for is additional changes that none of us have ever seen, and bring it forward to, we're going to make it open to everybody so that you could every agency should take a look at this. And we've already been contacted by Senator Rivera's office. He's the chair of the Health Committee on the Senate side. They want information from New York City. So we're going to be working to get that to them. And also we'll be working with NYSARA and Onion so that we can, be a unified force to protect EMS, not just in New York City, but in New York State.
Any questions for Marie? Okay, CMAC did not meet, but I do want to bring up this credentialing subcommittee that Paul is chairing. So there has been a subcommittee at the CMAC level that has been tasked with basically defining what the role of REMAC are with regards to credentialing of providers. This stems from a case upstate where a REMAC pulled the credentials of a provider. That provider then fought this legally and was told that the REMAC doesn't have the authority to pull pull their credentials. And that has sparked a large discussion on what is the role of the REMAC in terms of credentialing. Now, the state has said that their legal counsel, and I say quote unquote legal counsel because the document that they provided was a letter from them to a region, says that the REMACs do not have the authority to credential providers. And it's something that we've always done. We give out REMAC certifications. If we're giving out a certification, it would make sense that they have a credential, and if they don't have it because we feel that they shouldn't have it, that would be decredentialing them. So that discussion has come up. Paul has been I don't know what's chairing that committee very, very nicely and very willingly. Not really, but it is a very interesting conversation, and the state, like I said, the state's position is one that we don't have the authority to do this. I think that that's something that's come up and has been discussed. They wanted to change it from credentialing to registration, and it's a very challenging conversation every Monday. All right.
You know, this is an issue that has been discussed in many forums throughout the years. Fact of the matter is that in general, credentialing is a process that is left not to, certifying bodies, but left to individual agencies. So that's where the credentialing really needs to take place. What we offer via our system is a credential to operate within this region. Okay, that's different from credentialing, which is done by the individual agency. The agency says you have a state certification, you have a REMAC certification, therefore we can hire you, and we can allow you to do the things that you are trained to do, and that you've been certified as competent to do. So, I think that the terminology here is very, very important, that we stick with what are the nationally accepted terms. What we do is certify. It's not, we don't credential. And so, we cannot remove someone's credentials. We can remove their certification, and we can publicly, notify the region that they no longer are certified. And then it's up to the individual agency to determine whether that individual will be decredentialed by the agency. But that's the tack we need to take.
I would agree with you, except that, again, the terminology is very critical. We do not certify anybody in New York State. That is done by the state with your EMT certificate, that is, or EMT or paramedic certificate. We don't have the authority over that certificate. We do have the authority
over the state certificate at all, but we do have authority over our own certification.
Yes, but I don't know that it's considered a certification or a credential to operate in the region. But again, I think that the problem becomes, we have a region with has a lot of involvement. Our process for credentialing and decredentialing of providers based on restrictions, and so we have a restriction policy in the region that relies on the medical directors of all the agencies to operate together, and it gives them the choice. Meaning, if the fire department restricts somebody, I have a choice if I want to restrict that person from my agency. In the event that it's found to be egregious, I can still let them work. Now, the fire department operationally manages the 911 system, but if I want them to work on a non-911 ambulance, I have the ability to do that if I choose. They're still certified to work as a paramedic. The issue becomes in some other regions where there are dictatorships, for lack of a better descriptor, and REMACs that overstep their authority or don't have a very large REMAC, and it's an issue. So I think that our region is a little bit different than a lot of others, but that is exactly what this conversation is about. What is the line? What is the proper terminology? How to apply it? And then what is the authority based on statute for region? I'll go with John and then Paul.
I just want to answer Art. What you said is
Paul and then John.
you're right, and vernacular standing. Things and no vocabulary, the choice of vocabulary.
Definitions.
has been,
But the national scope of practice document has formed the backbone of our understanding, and that
is
is
the
retort to your comment. I wanted to give a report.
So retort, I mean, I don't like that. What I stated. More or less.
I have words you wrote right in front of me, Art. I can't believe I said that out loud.
All right, John.
So yeah, so I mean, listen, for lack of better words, the original sin is actually calling, our paramedics to be certified and not licensed, because if someone does a job and no one else can do it, and if you take it away, you can't do it, that's a license. And like, that's kind of what, like, that's the origin of some of this. And so then we created this other term, and then now we got to this other term of credentialing. And so hopefully the goal is to get us to the national model, which I think is in the national model, they are licensed by the state, certified by a body that is a certification body, credentialed by a medical director, and compensated by whatever body that does. It's a tragedy that and it wasn't just one issue. There's been at least 3 issues I'm aware of in the state that challenge this issue. But it's a tragedy that this is happening in areas outside of New York City, and that this impacts the city, because speaking as someone who's a medical director of an agency that operates in multiple regions, I have more interactions with the city system than any other system, but I have fewer problems. So there's a lot that I think that people can learn by how this region, this system operates. That being said, I think that there are a lot of people talking about kind of this idea of either delegation or kind of understanding that the credentialing can be kind of for lack of a better word, delegated to another body, which I think that from my perspective, I have no problem, because I have a lot of trust in this system. But as a medical director of an agency, I think that it is that when it comes to credentialing, it is for me to have trust in that system in terms of how it comes, in terms of being credentialed. And that is kind of what the national model set up. That's kind of what we're trying to move towards. I do think that this starts with this whole idea of licensure, and we have to kind of go back to the definitions, get the definitions right from the first time, so that the model works. And with Paul's guidance, hopefully we will get there someday.
So amazing. We're trying to reset the discussion and finally getting some traction. There's 4 policies in the Bureau of EMS that have to be revised. Current state of this group is a survey going out to program agencies to fill out and figure out basically state what their standards are at this point, and ideally cross-pollinate information and get to some best practices
with regards to standards. I just want to say, that credentialing paramedics is
of standards will weak in the field. So the idea of a lack of a regional credential, state provided credential, will actually take paramedics backwards. And that's something that I really don't want to have happen. So this in a future state may have a totally different look, with either skill credentialing as opposed to regional credentialing, individual skill credentialing, what I'm saying, things like that. I don't know where it's going to go, but there's another region that has it.
annual offset.
I mean, that you have to, be in it to win it. So you fall off if you don't maintain your status. So there's a lot of information that's going to be shared. But the statutes were used to basically restrict people from an ability to earn, which is a tragedy. And that's where a lot of this is stemming from. No one should be withheld from their ability to earn their license as they can.
Okay, hold on one second. Let's go with Ben and then.
And maybe this is already happening. I mean, it seems like the discussions in the past have been a lot of feeling that Article 30 should say this, or we should have this power. We've historically done X, Y, Z. So hopefully, in addition to working with the Bureau, there's some effort to try to get this updated to Article 30, because I'm not a lawyer about the delegation. You know, if there's something that is not specifically granted power, but medical director authority for that. Yeah, I think this needs to not just be about paramedic. If there is a regional.
Including physicians.
No, agreed. And the challenge is that Article 30 is discussable, or I don't know how.
Well,
it's-
vaguely worded.
It's confusing.
Right.
It's not worded clearly. It's usually worded in the negative, and it's not. So it lends itself to a lot of interpretation, and the state has said that they have a legal opinion, but they didn't demonstrate that. They didn't show that to anybody. So it is, we are looking into other avenues to get other legal opinions to then go to this committee and say, you know, we have this legal opinion. Can you show us yours? And let's come to an understanding. Art.
Just to answer Ben's point first, you know, the only body that under the most general understanding of American law, you know, with respect to credentialing of individual providers, it's the board of directors of the given entity that is allowing the person to work. The board of directors can, if it wishes to do so, delegate its authority to the medical director, but the ultimate authority rests with the board of directors, not with the medical director, not with anybody else. That's the person, or the in fact the president of the, or chair or what have you, of the particular service involved, be it a hospital, be it a whatever, you know, be it an EMS service. It's the signature of the chief executive officer of that entity on a piece of paper, you know, that is the proof that you have been granted credentials by that entity. Now let's take a few steps back here, to follow up on some of the comments that Joe made. Part of our problem here is that, you know, the Lombardi law, which is what we call the original version of Article 30, because it was pushed by Tarky Lombardi, who was you know, a major player in the Senate back in the 1970s. You know, there was a much more limited understanding of, you know, these terms, you know, credentialing, privileging, licensing, et cetera, than there is now. There's also the historic fact that in the state of New York, professional, you know, shall we say, issuance of a document that says you may do certain things to the public, that issue of licensure has always rested with the Department of Education, not with the Department of Health. No one was ready back in the day to, you know, allow paramedics to be licensed, although that is what probably should have been done from a legal standpoint. So this term certified ends up in Article 30, when, as has already been pointed out at this end of the table, you know, it is in fact the certification issued by the Department of Health is in fact a license, because it's a governmental agent, an entity is issuing, you know, a document that gives an individual the right to perform certain things, you know, for the public, to the public, if you wish. Okay. In a sense, what we do here in terms of certifying is no different. We're saying, and as a quasi-governmental entity, we are written into the law after all, you know, as a quasi-governmental entity, we are also issuing, if you will, a license of sorts. Now, you know, the state is very jealous about you know, that it is the only entity which is actually allowed to license anybody. And particularly the Department of Education is all over that one like a new suit. But the fact of the matter is that if you are a governmental agency or quasi-governmental agency and you are issuing permission to do certain things for, or, you know, the public on its behalf to the public. Okay, that is in, you know, in the sense that everybody in the rest of the country, most of the rest of the country, and the legal experts understand the word, that is a license. You know, that is a license. The credentialing, okay, is done in most other instances by an outside recognized body, such as NREMT. Okay, that's the actual, you know, confirmation of, you know, or the recognized way that that an individual's, you know, skills, you know, knowledge, skills, and attitudes are recognized as, you know, in terms of competency. So as close as we can get to those terms, the better off we are. I certainly hope Paul is going to lead this group in that direction. But this actually could be end up being very good for us in the long term, you know, because we might actually end up calling what it is that we do licensure, because it is. Then the question becomes, you know, do we have the authority to do licensure? The Department of Education would say, hell no, you know, only we have the authority for professionals, you know, to do licensure. But ultimately, that's not up to them either. It's up to the legislature. It's up to the people of the state of New York and in Senate and Assembly represented with approval by the governor. Okay, that's where those licenses come from. They come from the people through those bodies. They don't come from anybody else. You know, so I have chosen not to join this group because I know it's been terribly contentious and so on. But tonight's discussion has, you know, has moved me to write a letter to you all, Paul, detailing some of these thoughts and you know, and making clear the direction that I think is the only viable direction for us to go.
Thank you, Paul. Glenn?
Yeah, you know, I think it's very interesting. In the summer when Greenberg came to meet with us, he told us directly that their legal said that it was illegal for the region to have this certification exam. And that puts it in a little bit of a loop. Kevin was there as well, and we looked at each other and went, oh crap, what are we supposed to do with it? So it's interesting that he said that. And he did say that, hey, as the oversight for the EMS system in New York City, we could have a certification exam to be able to work in the 911 system. After hearing some of this wording, I thought, why the hell would I want to do that? But that's a separate issue. So it's interesting to me, though, that as much as they're saying it's illegal, there's no cease and desist that came from that, right? This seems very similar to what happened with ADAC, the Ambulance Destination Advisory Committee. That was a standard that we all, you know, as a region decided to have. And in '99, Ed Ronsky, who was the director of EMS at the time, came to one of our meetings and immediately ordered a cease and desist. And that was similar to, there was a caseworker who was let go because they didn't meet the ADAC requirement of a social worker, a little bit higher education. And they said that the REMACs had no authority to regulate the hospital when the state did so, which is similar, I think, to what's going on here. But this is going to be very interesting. And we all know, you know, licensing and certification, essentially it's the same thing. You're calling it one thing, but, you know, maybe legally on paper it's not, but essentially we're always told it's kind of the same thing, right? So this will be interesting going forward, what's going to happen.
So just to wrap up, I encourage anyone who wants to participate in the meetings, please come. I will say our region
Is well represented and well spoken for at the meeting. A lot of good feedback from other regions, Southern Tier.
some stuff to borrow from them, but ultimately, hopefully in a future state,
As we continue to learn from each other, there'll be one other piece that I think we're well positioned is our quality department here.
the other region, licensure is semi-arbitrary, and
Our due process.
feedback from this survey, which we should have in 2 weeks, and hopefully more to tell. But if you want to participate in the meeting, by all means, just contact me privately, and we'll get you added to the group.
Yeah, Glenn, but I agree with you. That's a very interesting point that he made, that it's illegal. But there's no cease and desist, and the legal document that they submitted was not a legal document. So it was very, very difficult to understand what their source of this legal issue is, but
Write that document, but they didn't want to open the survey.
go ahead.
Yeah, just two things. So, in other communication, I think there have been some cease and desist, not about the city.
Right.
And then lastly, I do think it's important, and we talked about this at the meeting on Monday, that what we don't want to do is precipitate our own crisis. And that's my biggest concern, is that if there is a formal legal opinion without enough time for people to prepare for change, it's going to be very, very tumultuous on our systems. And so I do think it's important that we kind of pay attention and kind of work with the state to get to that homeostasis where we can actually make sure, because the instability of this is a big deal. This conversation is one of the biggest things to happen in New York State EMS in a very long time. Obviously really happy that Paul's taking the lead in this, but I want to make sure that if this goes in a weird way, it could be very disruptive. And I think it's important that everyone's going to have to compromise for sure to prevent probably a disruption. And there's some outcomes I could imagine being very disruptive that I don't think any of us in this room want.
I would agree. Any other comments? All right, there's two, so there's no unfinished business, but there's two items of new business that I want to discuss quickly. Bob Krupe, are you still on the Zoom? I don't see him, but okay, so we have an application from Ridgewood Volunteer Ambulance Corporation. They have submitted to Hudson Valley for the iGel project. They have all the paperwork submitted to Hudson Valley, and they are coming to us for our notification so that they can proceed with the iGel pilot through Hudson Valley. Dr. Krupe is their medical director, which is why I asked if he was still on here. The agency contact is Sean Graves. Their paperwork is all in order. And we just need to sign off on it to send it to the state. I'm just bringing it up here for information. And they will meet the same requirements that we have asked of Jamaica and everybody else.
So.
Correct. No, so it's a pilot project that Hudson Valley is running. Anyone in the state can apply to do BLS iGel through their. They're managing the QA. They're managing all the aspects of the pilot. Correct. But in order to do it in our region, you need to inform us, and you need to make sure that all the paperwork is in. So. For this agency. Yep, over here.
I'm sorry, what's the agency and where are they planning to do it, in New York City?
It is Ridgewood Volunteer Ambulance Corps. Sean Graves is the agency contact. They use Sancio as their EPCR vendor. Bob Krupe is their medical director. They operate primarily in Queens. And their primary receiving hospital is kind of as NYC Queens.
As long as they follow the advisory that we worked very hard on publishing, Dr. Redliner and his group.
Correct.
Should be fine.
Yeah, that's why they're submitting the paperwork now before. Glenn.
So besides the two, I guess, initially Jamaica and Flushing.
Jamaica and Flushing is one.
Okay, so
system.
Okay, and then now Ridgewood. No other BLS providers. Okay, and do we know if there been any iGels placed by
I
anybody?
haven't heard it.
Okay,
There you go.
January 17th. By a Jamaica unit or? And only one so far. Thank you.
No problem. Okay, so that was really more informational. But yeah, I agree, David, as long as they're following the process, they should be able to do it. Okay, finally, there's an application for ALS from Khazde Devora, which operates as Ezras Nushim. They're submitting an ALS application to upgrade from BLS to ALS. The one piece of information that we're going to discuss it, but their application is complete. The one piece of information that I want to make clear to everybody is they do only have one paramedic on staff. They have 38 EMTs. They only have one paramedic. But they are requesting to become an ALS agency.
How are you gonna operate an ALS agency with one paramedic? I mean, I'm all for people upgrading, but I just don't understand how are they on 24/7? How is that gonna work?
Again, I think that
Marie has more
Marie's gonna explain a little bit more.
Okay, our policy doesn't require a certain number of paramedics.
No, they just have to meet the requirements. That's
You
it.
just have
Yeah.
to meet the requirements. They can't obviously operate as ALS. The reason many agencies that upgrade ask to be upgraded is because they cannot send their members to paramedic class and be reimbursed without being upgraded to ALS. So we're in no danger of them descending on New York
So
City. with their
just
one
because
medic.
we approve the upgrade doesn't mean they're gonna operate tomorrow
Yeah.
as a.
Absolutely,
Do
but
they
they
have
will
to-
be sending their students to paramedic class and getting reimbursed by
Alan
the state.
Shearson is their medical director.
There you go.
As Russ Nushin.
Medical control through Northwell.
So if we allow them to upgrade, they would be in effect able to operate at the ALS level with their one provider though. I mean, we're saying that they're
Technically,
doing
yes.
it they're doing it to have people go to paramedic school, but they would be able to operate as ALS.
Right, but to Marie's point, my understanding is if an agency meets the requirements, to upgrade, you can't, it's not like a CON process. If they meet the requirements, they meet the requirements and they get the upgrade.
Yeah,
The volunteers can operate with one medic.
Yes. Volunteers operate with one medic. They only do non-911 generated calls. And we,
Yeah.
haven't used this against any other agency.
No, I'm right. I mean, if you meet the ALS, the regional ALS plan, you meet the regional ALS plan. You
I mean,
can't.
volunteers who are in the system who maybe have 3 medics.
Yeah.
So it's not such a big leap. They want to be able to work at this level if they have the provider available and to send their people to medic school and get reimbursed. I can't imagine any reason why you wouldn't want to just let them try and improve the quality of the care they provide.
I think that makes sense, especially if they want to send students to paramedic school. But we do have volunteer units in the 911 system now. I mean, right?
Yeah.
About 175 to 200 calls a month right now. And they have to meet the same standards of 2 paramedics for that
To
situation.
take a 911 call, yeah.
And they were supposed to be low priority, but they are going to cardiac arrest. They are going to things. So we just have to maintain that
Well,
standard.
so
for
then
911.
we might have, Marie, do they respond in the 911 system?
No, I don't believe that Ezra's not should respond to the 911 system.
We'd
They're
have to find out.
Yeah.
If they do have a 911 designation, they'd have to we'd have to send them a letter stating that they cannot operate on a 911 generated call without 2 minutes.
Right. They'd have to meet that standard. Yeah.
website as part of our standard. Our standards are broken up into response for 911 generated calls and non-911. And if you're doing 911, you must have 2 paramedics or 2 EMTs. Right.
Right, but if they're an agency that's doing both 911 generated and non-911 generated, I think it should be clear to them
Worth
that for
reminding them.
911 calls, they need to have 2.
That's not a problem. With our approval,
Yeah.
we'll put that in the letter.
Yeah.
Any more discussion on this agency? Any concerns? Okay, hearing none, all in favor of approving them as an ALS agency, please raise your hand. Anyone opposed? None, okay. All right, I have no further new business on the agenda. Does anybody else have any new business they want to bring to the table? Paul and then Joe.
Want this
Many years of work.
Staten University Hospital.
Snake bite prevention treatment.
Are they a snake bite center?
Patient was bitten by toxic puff adder, and within 2 hours after 911 delivery to our facility by Maymont EMS, patient AMD venom delivered and administered, and first platelet count was sub 100. So this was a legitimate event.
Legitimate toxic event, and everything worked out well. So for all the jokes, for all the years, we saved a thumb.
Thanks, Paul.
Thank you, Paul.
Joe.
Use the mic. Follow your own rules.
Just a friendly reminder that this is the 50th anniversary of the Regional EMS Council coming up this May. And as such, we are going to be doing a special celebration for EMS Week, holding our event at Russo's on the Bay in Queens. We invite everyone to attend.
Coming through.
No, Maria's. So save the dates are going out, registration info is to come. But also with that, registration will soon be opening up for our EMS Week Awards, and we strongly encourage folks to apply. We know you all have great providers that do wonderful work, and they should get the recognition for it. So please be on the lookout for when those registrations open.
Okay, Dr. Harris.
Yeah, just really a quick pitch that it's the 40th anniversary of EMS for Children this year nationally, 1984. That was 2, just for the record. And it's an excellent opportunity for those agencies who have not yet identified a pediatric emergency care coordinator to do so. I think it's going to be something that will be very much in the benefit of your agency. There are online resources that are free. You can reach out to myself and obviously Dr. Cooper if you have questions about how we can help facilitate this with your agency. One other last introduction, it's okay. Mark Hanna, who's I'm going to embarrass over there behind you, just hanging out with us today, is a recent graduate of the Newark Robert Wood Johnson EMS Fellowship, also Peds Emergency Medicine trained, so another great voice for the community.
Welcome. Excellent. Hearing no other new business. I
Motion to
will
adjourn.
Entertain a motion. Marie, you
No,
have one?
I'm just gonna reiterate what Joe said. Sorry. Help support our EMS week.
Excellent.
Please go back to your agencies and open up
Motion
your
to
wallet.
adjourn?
Thank you.
All right. Thank you, everybody. Much appreciated. We should add him